All right. Hello, everyone. The team that's joining us online and those that are present in the room, good afternoon to you. You are welcome for this 110 echo session. Just as a reminder, these sessions are brought to you by Seed Global Health in collaboration with the Ministry of Health. Today we're going to be talking about a very important cardiovascular condition that spans a breadth of practice, ranging from pre-hospital care to the in-hospital setting. In the room, we have a team of experts who not only have the knowledge of managing this condition, but also have the experience of teaching it. We also have two other experts online, and so that the ones that are going to be taking you through this session of the cardiovascular emergency that we're going to discuss. So I'm going to let the experts introduce themselves, starting from the ones that are present in the room, and we'll have the ones that are online go afterwards. So we'll go from my left all the way to the extreme right.
Good afternoon, everyone. My name is Isaac. Glad to be here. I'm an EMT, and I'm looking forward to having a good time for all of us. Thank you.
Good afternoon, everyone. Good afternoon, everyone. My name is Imelda Namatovu. I'm a registered nurse, critical care nurse, and I work in Bombo Hospital. Thank you for coming.
Yes, ladies and gentlemen, good afternoon to you all. Moses Tenyo is my name. I'm a doctor and currently an emergency medicine resident in Maya 1 at Makerere University. Thank you so much.
And my name is Joseph Senkumba from the Apple Training Center, where we do courses, and I am here to support the scenario-based exercise. I am excited about the outcome of this session. Thank you. Sorry about our light. We had to divide it. It's not a serious problem, but you will realize why we had to divide our light. Enjoy the session.
All right. So those are the team that are present physically in the room that are going to be taking you through the demonstration of how this cardiovascular emergency is managed. But also, like I mentioned, online, we do have other experts who are going to be handling other parts of this program. And so I'll let them introduce themselves. I think we can start with Dr. Daniel Olinga, and then we'll have Dr. Oriba afterwards.
Thank you very much. I am Daniel Olinga, an emergency medicine physician and the lecturer at Mbarara University of Science and Technology. I'm glad to be here, and let's enjoy bringing this racing heart to normalcy.
All right. The next expert that we have online is Dr. Oriba. So Dr. Oriba, if you're on, could you please unmute and introduce yourself? So it looks like we don't have Dr. Oriba online, but once he comes, I think we'll give him a moment to introduce himself. We'll also be making a presentation at the end of the simulation, and so I guess you might as well have to use that as the opportunity to talk about himself. So just remember that I forgot to introduce myself. So my name is Dixon Kamoga. I'm a resident of emergency medicine at Makerere, and I'm in my final year. So today I'm going to be the one moderating this session. I think we now have Dr. Oriba online. So Dr. Oriba, if you can hear me, could you please unmute and introduce yourself?
Yes, thank you very much, moderator and everyone present. I'm Dr. Dan Oriba Langoya. I'm an internal medicine physician at St. Mary's Hospital at Cho, head of department and also honorary clinical lecturer, Department of Internal Medicine, Gulu University, Faculty of Medicine. So thank you very much for being here.
All right. Thank you, Dr. Oriba. And we're very glad to have you for this session. So we're going to be walking through a very systematic program. And so everything is like well laid out. So the next activity that we're going to go for is we're going to have you guys online share a bit of what you have as expectations for this session. So I'm going to ask you if you can type in the chat, just type out those things that you expect the experts to talk about during this session. And also, you can as well unmute yourself and we'll select, raise your hand and we'll select on you to also voice out your expectations. So you can use the chat to share your expectations, or you can put up your hand and we select you to speak. All right, so it should take us about 5 minutes to do, and then we'll afterwards go into the next activities on this program. All right, so you can use the chat or you can raise your hand and we'll select you to talk to us about what your expectations are for this session. So like I said, we're going to be talking about today a very important cardiovascular emergency that spans across the practice of emergency care from pre-hospital care to the in-hospital setting. And we're going to have these experts that have just introduced themselves to you do a practical demonstration of how to manage this cardiovascular condition. And we'll have a presentation at the end from another expert who will just be giving us the theoretic components of managing this cardiovascular emergency. So you can use the chat to tell us what your expectations for this session are. And also, you can as well raise your hand and we select you to speak. All right, so we're going to be closing this session in the next 1 minute. I see some expectations are already coming in. So you can utilize the chat, and then, so this gives us a clue on what things you're having as expectations, and we'll be sure to tackle them during the discussion. So that's why this particular session is very important. All right, so at this juncture, I think I'll be closing this segment of you guys sharing your expectations, and we'll go to the next item on our agenda, which is going to be starting the practical demonstrations of how to manage this cardiovascular emergency. So I'll have the first group of experts going to do a physical demo of this, of managing this cardiovascular emergency. Take the scene and they will demonstrate to you how to manage it.
Okay, we will start our simulation to show you the pre-hospital care of such an incident. All right, you're on ambulance today, Isaac?
Yes, I am.
How has been your afternoon?
It's a good afternoon, sir.
Cool. So we just received a call from Ntinda, home in Ntinda. There is a 48-year-old Peter who has been having palpitations for the last 6 hours.
The last 6 hours.
Yes, the family is scared and they called EMS to go and intervene.
Okay, so I'm responding to Ntinda.
Yes.
There is a 48-year-old male, Peter.
That's right.
Who has been complaining of heart palpitation for the last 6
That's 6 hours, yes.
So is the scene safe?
The scene is safe for you to approach. They don't have a dog. It's a home.
Yeah.
And I am told that the gentleman, Peter, is in their sitting room in a coach.
Any additional information you should know about?
He has been going to hospital regularly, but this time he couldn't make it. Yes.
All right. Okay. With my PPs on, I'll approach the scene where Mr. Peter is. Okay. All right, Mr. Peter, Mr. Peter. Mr. Peter. Mr. Peter.
Yes.
Okay, how are you feeling today?
Yes. So you see, Mr. Peter, he can look at you.
Okay.
He seems a bit anxious, and he can talk to you actually.
Okay, Mr. Peter, my name is Isaac. I'm from EMS. I'm
Yes.
here to help. Okay.
Thank you.
You mind if I touch you?
Yes, it's okay. Please touch me.
Okay, Mr. Peter is talking to me, so the airway is parted. Okay, on exposure here, what do I see?
So you see a clear chest, no signs of injury.
Okay.
And it is moving up and down.
Moving
The
up
chest
and down.
movements.
Okay, on palpation.
It's good. No signs of emphysema. It looks stable.
Okay, respiration rate.
When you count it, it's around 21 breaths per minute.
21 breaths per minute. Okay.
Yes.
Okay. How is my trachea alignment?
It's centrally aligned.
Yeah, I need to find out the SpO2 of Mr. Peter.
Okay, we need to do that.
Putting on the SpO2 probe.
Okay, we need to see here.
Okay. When I put on my SpO2 probe, that's my SpO2.
Okay, you can see it on the monitors. 96.
96%. Okay. On percussion.
No more resonance. No more resonance. No more resonance on all sides.
Okay. How is my air entry?
There is good air entry on the left, good air entry on the right, good air entry on the right base, good air entry bilateral.
All right. Okay, I'm going to proceed with C. How are my extremities?
The extremities are warm.
What warm extremities?
Yes.
Okay. Cup refill.
It is 2 seconds when you count 1, 2, 3, 4, 5. It refills in 2 seconds.
2 seconds. Okay. My radial pulse. What's the rate?
It's palpable, strong, around 180.
Around 180.
1 minute. Yes.
All right.
And regular.
Right. I need to take blood pressure.
Okay.
Okay, Mr. Peter, you're going to be okay. We just do check. Okay, recycling the blood pressure.
All right, it will come.
Okay, how is my jugular veins?
The jugular veins are not distended.
They're not distended.
Yes.
Okay, I'll connect my ECG. Okay, listening to the heart.
So the heart sounds 1 and 2 are hard and not muffled.
1 and 2 are hard and not muffled. Okay.
So the ECG gives you this.
Okay, we've got
Because
analysis.
we got okay.
Right. So the team online, that's the we've just projected a poll. So the team online, we've just projected an ECG reading for this particular case that we're managing. So at this point, we'd like you to take part in this discussion. Use the chat section to comment what this reading could be. So as you can see, we have an ECG reading that's projected. So I want to get you engaged in the discussion. And I want you to use the chat and try and tell us what you think this reading is actually. So we will go ahead and discuss for you what it is and how to manage it. But at this point, we want you to get engaged in the discussion and tell us what this reading means. You can as well and raise your hand if you just want to speak to it, and we'll select you to speak. All right, so let's keep those messages coming. We just want to assess the level of knowledge, the baseline knowledge that you guys online are having before we get into the nitty-gritty of discussing this particular kind of emergency. All right, so we have a couple of people saying it's SVT. Okay, so another person on my goal come and says it's SVT. All right, you can keep the answers coming through. In the next 1 minute, I'll be closing this session and we'll go back to our demonstration. All right, so Colin says it's SVT, or Tim David says it's SVT. All right, Teddy says it's SVT. Dumba says it's narrow QRSI, not touchy. All right, so we like all these opinions, and like I said, we're going to get into the discussion of this cardiovascular condition. Emma says it's SVT, Biruni says it's SVT. All right, so I think at this point we'll close this session, and we'll have the experts go back to demonstrating how to manage this condition. At the end, we'll have a discussion of what it is and how to manage it. So thank you to everyone who has kept the answers coming through. And you can as well just continue typing the answers as we go through the demonstration. All right, so I'll have the experts demonstrate again how to handle this condition and also tell us what it is.
So Isaac, you continue your assessment. We paused when you are doing a rhythm analysis.
Okay, according to the rhythm we are having, we have a pulse rate of 180 beats per minute. We do not have a P wave, and we have a narrow complex. Guys, we have a supraventricular tachycardia here. So we're going to do vagal maneuvers to help relieve the patient. Okay. Mr. John, Mr. Peter, Mr. Peter.
Which kind of vagal maneuvers?
Okay, we're going to begin off with a syringe blowout, and then we'll discuss other maneuvers.
We stop. Okay. Let's make a pause.
All right, so at this point, we also wanted you to respond to, so before we do the vagal maneuvers, we wanted you to tell us what you think are the precautions to take before doing vagal maneuvers. And so I see a couple of you have actually responded already. So we're going to take a moment now to tell you actually what you do before you do your cardiac maneuvers. So I'll end the poll at this point, and then you'll assess yourself based on the choice that you selected and what the expert is going to tell us the actual maneuvers, the actual precautions to take before doing cardiac massage.
Okay, Isaac, you decide that this patient needs to get vagal maneuvers.
Yes.
And please go ahead.
Okay, pre-hospital wise, we wouldn't want to do carotid massage because of the various precautions. Okay, like we need to obtain a 12-lead ECG to rule out a STEMI. We also like to auscultate the carotid to rule out the Brooks sound, and also we would like to know the past medical condition of the patient, which we may not be having at the moment. So I would prefer pre-hospital wise, we stick with the syringe and then the ice pack maneuvers. Okay, so I'm going to assist Mr. Peter. Mr. Peter.
Yes.
You're going to block the slit as much as you can for about 15 seconds.
You want me to blow there?
Yes, please. Go ahead.
I am trying, but I can't. Air is not coming.
Air is not coming.
Yes.
If your patient cannot do that, you can also shift his legs. Mr. Peter?
Yes.
I'm going to help you and move your legs.
Okay. Okay. You're lying me flat?
Yes, I'm lying you flat.
Okay.
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 Also raise 6 legs at an angle of 45 degrees for 15 seconds.
Okay, so you do that and you look at your monitor, nothing is changing.
Nothing is changing. Okay. 15 seconds. Done. Okay. Mr. Peter?
Yes.
I'm going to put an ice pack here. It may feel uncomfortable, but it will help you feel better. Okay?
Okay. Okay.
Right. Right. I'll place my ice pack.
Okay.
While monitoring my heart rate on the monitor.
Okay.
Okay, we can see my heart rate is dropping. And I have a heart rate of 134 beats per minute. Mr. Peter, how are you feeling?
I am feeling better, thank you.
You're feeling better?
Yes, thank you.
Okay, so we have a sinus stucky, but you're feeling better. So
Yes.
Okay, I'll continue with my assessment. Okay, Mr. Peter, are you still with me?
Yes, thank you.
Mr. Peter is still responding. Okay, I will check for prior response to light. How are my pupils?
So both eyes and pupils are equal and reactive to light.
They're equal and reactive to light. Okay, I will check for my RBS. What's my RBS?
So when you check, the RBS is 5.7.
5.7. Okay, that's okay. All right. Okay, on all exposure the question, do I see any deformities anywhere? Bruises, lacerations, sore wounds, anything?
So you see nothing.
Nothing.
It all seems clear.
Okay, checking the temperature, my patient.
So the temperature is 36.4.
36.4. Okay, that is good. I'm still reassessing for my heart rate is still 130. Okay.
Yes.
All right. Okay, Mr. Peter.
Yes.
Okay, I'm going to have to take you to the hospital.
Okay.
Because the heart rate now is low, but it may reoccur and then you go back into palpitations. And when your heart is beating faster.
Yeah.
So I'm gonna have to take you to the hospital for further management and investigation.
I know the risks they have been telling me that. Please take me.
All right.
Okay, so the next thing is that we coordinate with the hospital and then have this patient transferred to the hospital.
Right.
We will pause the pre-hospital bit and continue with the program, moderator.
All right. So we're going to project a poll questions that I want you guys to respond to. It's just an introduction to what now we're going to learn once the patient arrives to our hospital's emergency department. So this poll is asking you to respond to this question, and it says that in a hemodynamically stable patient with SVT, which we just seen being managed, which medication is then implemented in the management. So once the patient now gets to the hospital, in case the SVT reoccurs or the maneuvers fail to work that were done in the hospital setting, what medication is indicated to try and revert this supraventricular tachycardia once the patient gets to the hospital. This is a particular poll that we want you to respond to. And then the next session will have you guys told what medication is and how to exactly administer it. All right, so what we just said for the previous couple of minutes has been the practical demonstration from the experts on how to manage supraventricular tachycardia in the pre-hospital setting. So a lot of you guys, when you projected the first rhythm, you're able to recognize that it was an SVT, which was actually a good thing. And the expert also gave us reasons why it was actually an SVT. And if you recall, he said the rhythm was rapid, the rate was 188, there were no discernible P waves, and the rhythm was narrow, the QRS was narrow. So those are the features that you look for when you're analyzing the rhythm strip to try and tell it's an SVT. So the case that we've just seen was of a patient with hemodynamic stable in the pre-hospital environment and was having an SVT. The expert demonstrated how to do all the three maneuvers to try and reverse this SVT back to sinus rhythm. A key thing to note was that we went through all the three maneuvers, and the reason that's recommended is because one maneuver might fail to work, and so you will need to try and explore the other maneuvers. So one thing doesn't fit all. If one maneuver fails to work, then you can try the next one, and eventually at least something will work out. So now what we're going to see is a patient arrives to the emergency department from EMS. Then what do the clinicians in the ED do for this patient? Like we said, the SVT could reoccur or the maneuvers could have failed to work. All right, so at this point, we'll end the poll. A lot of you have answered. Now, Miodaron, a few have answered adenosine. So we're going to learn how exactly what to do for the patient. All right, so we now move to the hospital. The patient has arrived by EMS. Okay, so we'll have so before we get into the hospital environment, we'll have the expert who has just taken us through how to manage the SVT practically, give us a bit of theoretic hints on how to do it in case you ever get faced with a patient presenting like this. So over to you, expert, to try to take us through the theoretic bits of managing SVT.
Okay, thank you very much, Doctor. In pre-hospital, it's very paramount that we do not spend a lot of time with the patient, okay? First and foremost, we're gonna have to ensure our personal safety, make sure that where you're being sent to, you're safe, okay? And also when we are doing our assessment with the patient, remember to follow the ABCDE approach. And it's as we always do, whenever you find a problem, you fix it, okay? Our problem here was in C, circulation, where we had a rapid heart rate. And when we did an ECG, we had to find out that we have an SVT. Pre-hospital wise, it's not usually advised to do the carotid massage due to the precautions listed during the scenario. For example, you're going to have to auscultate with for the carotid to rule out a blood. You're also going to have to do a 12-lead ECG to rule out an ST elevation. Usually in our setting here, very few ambulances have got 12-lead ECGs. Therefore, that's why we leave the carotid massage specifically for in hospital. And also the application of adenosine in pre-hospital may also be proving a challenge, mainly because, of course, of the type of the ambulance you're using. Most ambulances we have, they don't have proper equipment to allow you to do that. And the drugs also on what? On board. Otherwise, we can stick to the Valsalva maneuvers where we can, where one uses a 10 ml syringe. You advise your patient to blow into it, and then you shift them immediately with their feet at an angle of 45 degrees, okay? It's paramount to continually assessing and monitoring your patient until you reach the emergency, the definitive healthy facility where this patient will have beneficial medical interventions and further management. Thank you very much.
All right. Thank you, Isaac, for that elaborate discussion on how to manage SVT. So at this point, we'll now move the patient to the hospital setting. So the patient arrives to the ED, and now at this point, the experts in the emergency department take over the management of this patient. Again, it's going to be a practical demonstration first, then we'll have a theoretic chat on what they've done, and they'll give you hints on how to manage the patient. So we do have another poll at this point where we want you to respond to this question and to help us assess your baseline level of understanding the condition that we're managing. So the patient now presents with palpitations, dizziness, and anxiety. What are the nurse's priority in the, nurse's priority initial actions? All right, so I'll have you respond to this in the next 1 minute. Then we'll go on to the experts demonstrating how to manage the patient upon arrival to the emergency department. So a lot of you are answering, assessing vital signs and cardiac rhythm. All right, so these are all great answers, and we're going to respond to them as we go through this discussion. All right, I think we can now move to the experts managing the patient once they arrive to the emergency department. Right, so I'm going to end the poll and we'll have patient managed in the hospital upon arrival.
So Isaac, you now arrive in the hospital. They receive your patient, give you a coach and bed to put the patient, and now you want to hand over.
Hey, good afternoon. My name is Isaac from EMS. I'm handling over Mr. Peter, a 48-year-old male who was complaining of palpitations for the past 6 hours. Okay, on scene, when we connected an ECG, we found out it's good SVT. We need about servo maneuver, and we were able to revert it to a sinus tachycardia of 130 beats per minute. Is hemodynamically stable throughout the transit, and I would like you to do further investigation and management.
Okay, thank you so much, Isaac. We are going to reassess the patient before we start, okay? Mr. Peter, how are you feeling?
The heart is jumping out.
Oh, the heart is jumping out. Okay, I'm going to do some things that are going to help you recover better. The airway is patent because Mr. Peter is currently speaking to me. When I expose the chest, what do I see?
So you see no signs of injury, but the chest rays are there.
Okay, do I have symmetrical chest rise?
It is symmetrical.
Okay, what is the respiratory rate?
Around 24 breaths per minute.
24 breaths per minute. That's quite high. Okay, when palpating the chest, do I feel anything?
No emphysema, the chest feels stable.
Okay, when I percuss?
No more resonance.
No more resonance?
No more resonance.
Okay, listening for air entry.
There is a good air entry on the left, good air entry on the right, good air entry on the bases bilateral. Good air entry. Good air entry.
Okay, we have good air entry. I'll attach the SpO2 probe. Is my trachea midline?
The trachea is midline.
Okay. What's my SpO2?
When you switch on the monitor, you will see that the SpO2 is 91%.
The SpO2 is 91. That's quite low. If I couple it with our slightly high respiratory rate, this patient needs some oxygen, so I'll give about 5 liters by nasal prongs.
Okay.
Okay, I have attached the nasal prongs. I'm now going to go on and assess circulation. Okay. When I attach the oxygen, do I have some improvement in the sats?
You have just started giving oxygen, maybe we give it some time.
All right. Temperature of extremities?
It is cold.
Extremities are cold.
Cold.
Okay, what is my pap refill?
So in 1, 2, 3, 4, 5. When you release, it is 4 seconds.
Cap refill is 4 seconds. That's quite delayed. What are the characteristics of my radial pulse?
It is strong, very fast.
Is it regular?
Regular.
It's regular. What's the rate?
Around 220.
Around 200. That's very fast. I'll take the blood pressure. Okay, when the blood pressure is checking, how am I jugular veins?
The jugular veins are not distended.
They are not distended.
Yes.
Okay, listening to heart sounds.
So heart sounds 1 and 2 heart not muffled.
Not muffled. Okay. I want to take a monitoring ECG. Okay. Do I have an ECG displayed?
Yes.
Okay. So we have an SVT of 222 beats per minute. Our patient has signs of shock. He has cold extremities, a delayed capillary fill plus rapid pulses. We have what's our blood pressure? 80/50 with hypotension and an SVT. This is an unstable patient. At this time, I'm going to call in an expert. Hello, Dr. Tenua, I need your help in the EP. We have a patient who is currently in an SVT of about 220 with signs of shock. He had initially recovered from one pre-hospital, which was relieved by vagal maneuvers. I think the patient might have deteriorated during transit. I need your help such that we proceed with the synchronized cardioversion. Okay, are you ready?
So Dr. Tenua starts running to your room.
In the meantime, I'm going to insert two large bore cannulae.
Okay.
And run a liter of fluids.
Sister Imelda, good afternoon.
Good afternoon, Dr. Tenua. You're most welcome.
Yes, what do we have here?
This is our patient.
Yes.
He's currently in an SVT of 220 with signs of shock.
So he's unstable.
Yes, he's unstable.
He has hypotension.
Hypotension, delayed capillary fill, and cold extremities.
Okay. So we're going to also call cardiology, tell them to prepare for this patient. For us here, what we're going to do, we are going to do synchronized cardioversion.
Yes.
Is that okay?
It's okay.
Okay. What's the name of our patient?
It's called Peter.
Peter.
Yes.
Good afternoon.
It's not good.
Okay, I am Moses, and we are going to try and manage your pain, and we are going to try to make your heart stop that fast heartbeat. Okay? We want to relieve you
out.
of that pain that you feel like it is jumping out.
Yes.
Okay, we are going to request for your permission to allow us to restart your heart. Okay?
What?
We are going to restart your heart by shocking it. Is that okay with you? Yes, we are going to shock your heart such that you do not have that feeling of your heart wanting to jump out of the chest.
Okay. Is it painful?
We are going to give you adequate pain management
Okay.
such that you do not feel anything.
Okay.
Okay, Sister Imelda, we have sought counsel from this patient. Okay? I hope our scene is safe. There are no metallic objects on this patient, any chains, anything.
Nothing.
Ensure that this patient does not have anything that could cause harm during cardioversion. Okay. So please administer 2.5 milligrams of midazolam IV. Okay? And you clap it.
2.5 milligrams of midazolam administered.
Okay. I would love for you to attach the pads. Ensure that the heart is centrally located in between the pads.
Okay, pads
Yes.
attached.
Pads are attached. Okay. Please select the juice.
How many?
I want you to select 70 joules.
Selecting 70 joules.
Synchronize.
Synchronized.
Okay. As you synchronized,
Yes.
charge.
Just a minute. Let's see for us to follow. Views are selected and we can see on the monitor it is synchronized.
Will you synchronize?
Yes.
Sister Imelda, I want us to check for safety again. Come and remove all the oxygen. That's oxygen delivery units. Confirm that there is no one. Please, everyone clear. Clear. Are you charging?
Charging.
Charging. Clear once again. Deliver the shock. Deliver the shock.
Shock delivered.
Okay.
So when you look at the monitor, it doesn't change after the first shock.
We still have an SVT, doctor.
We still have an SVT.
Yes.
Okay, you're going to raise to the next joules.
Okay.
That is going to be 100. Please select that.
Okay, selected 100 joules.
100 joules. Ensure that the scene is safe.
Scene is safe.
Okay.
Charging.
Charge. Charge. Deliver the shock.
Shock delivered.
All right. Okay, let us observe power reading.
Okay, doctor, it looks like we've attained a normal sinus rhythm.
Normal sinus rhythm.
With a tachycardia of about 147, but still coming down.
All right.
Okay.
So let us continue with our assessment. How is our RBS?
Let me start again. So, Mr. Peter?
Yeah.
Mr. Peter?
Yes.
Mr. Peter is still a bit weak.
Yeah.
Okay, moving on to D. How are our pupillary reaction? Check
Okay,
pupils.
so when you look at them, they are equal and reactive light.
Pupils are equal and reactive to light.
Yes.
Random blood sugar.
When you check random blood sugar, it's 5.7.
5.7 millimoles.
Very much, yeah.
Okay, that's also normal. When I expose the patient, anything significant?
Nothing.
Nothing significant. What is the temperature?
Okay, so when you check the temperature, it's 36.3.
36.3. Okay, that's also quite normal. Do we have any history of heart disease, medications being taken?
What we know, he has been visiting a cardiologist.
Okay,
Yeah.
okay.
Like
Let me
twice a year.
let me now reassess the patient. Mr. Peter,
Yeah,
Mr. Peter.
yes, yes.
Okay, but the airway is parted. When I expose the chest, how is the chest rise?
There's symmetrical.
Symmetrical chest rise. Percussion, no more resonance. Is the trachea still midline?
Midline.
Do I still have good air entry?
When you listen, there is a good air entry by
Good
electron.
entry. What is my current SpO2?
So you can check again, it has improved to 95%.
Just improved to 95. Extremities?
Extremities are still cool.
Still cool. What is my capillary fill time?
Now 3 seconds.
3 seconds. Okay. How are my peripheral pulses?
They are palpable,
Is it regular still?
regular.
Okay. What is my current blood pressure?
Okay.
Jugular veins?
They standard.
Okay. Heart sounds?
Still 1 and 2 are high, not muffled.
Do I still have a sinus rhythm?
Yes.
Okay.
The rate is getting down.
The rate is now 134. Okay. Mr. Peter, Mr. Peter.
Yes.
Okay. Mr. Peter is still talking to me. Pupillary reaction to light.
Equal and reactive.
Equal and reactive. What is my current random blood sugar?
Okay, it is a 5.7.
Okay, 5.7. So we have reassessed our patient. The patient has now converted from an SVT to a sinus tachycardia, and all our vitals are seemingly coming up. We need to transfer this patient to an ICU and also take off samples for cardiac enzymes, troponin, CKMB, as well as serum electrolytes to monitor what could have been the cause of the SVT.
Okay, do you want Dr. Tenua to get in touch with the ICU?
Yes, please. Dr. Tenua, would you please get in touch with the ICU such that they can prepare to receive Mr. Peter?
Oh, yes. Thank you.
Right. Thank you, Imelda and Moses, for that great demonstration on how to manage a patient with an unstable SPT in the emergency department. So the team online have seen, so once the patient arrived in the emergency department, the team has quick to react. The first responder did the initial assessment, and then only the experts to come in and cardiovert the patient. And as you see, there were 2 rounds of cardioversion, and by the second round that the patient was able to be cardioverted from the SVT to sinus rhythm. Again, the key thing to note is that it's always need for a multidisciplinary approach to managing such cardiovascular emergencies. After achieving the ED stabilized the patient, she called ICU, called cardiology, to try and come on to our hand management this patient. So the next thing that we're going for is we're going to have a brief theoretic chat from the expert about how to manage this condition. When you just see the but then they're going to chat with you how to do, so we'll have a poll that's projected on the screen. What we want you to respond to the question. So, as you're responding to it, I'd like to invite the expert, that's the elder, to give us the theoretic glimpses on how to manage this coalition. All right, so over to you, Imelda. I'll be closing the call in the next couple of seconds.
Good afternoon once again. Once again, my name is Imelda. I'm a registered nurse. I'm also an instructor of advanced life support of the European Resuscitation Council. So to start with, we are going to first of all understand, because as nurses, for you to be able to manage a patient well, you need to know how the disease process occurs. So first of all, we are going to first understand what the SVT actually does to your patient. So the SVT, it's a rhythm that originates above the ventricles, and it's usually characterized by a very rapid heart rate. Usually you don't see evident P waves. That is what differentiates it from a normal sinus tachycardia. So when the heart rate is very high, what usually happens is the heart, the feeling of the heart, the time for the heart to feel is reduced. So we have reduced diastolic feeling. And when we have reduced diastolic feeling, it means your ventricles will not feel adequately. Therefore, the blood that will be pumped out will also be insufficient to supply the heart. And that is why we say that you have a reduced stroke volume. When your stroke volume is reduced, it so happens that the cardiac output will also be reduced. If you remember earlier in the times of training, the formula for calculating cardiac output is a product of stroke volume and the heart rate. But with a reduced stroke volume, subsequently, your cardiac output will be reduced, especially in cases where we have prolonged tachycardia. And what does this mean? When this happens, the coronary perfusion will also be lowered, because usually the coronary arteries are supplied with blood during the time of diastole. And remember, now you have reduced diastolic time. So the myocardial muscle will instead demand for more oxygen. So in most cases, even when you have a normal SpO2 in cases of very high tachycardias that are persistent, your patient will still have a very high demand for oxygen. So that understood, the nursing care of such patients is dependent on whether your patient is stable or unstable. So if your patient is unstable, like the patient that we had in the pre-hospital scenario, usually blood pressures are still maintained, the patient is hemodynamically stable, and sometimes the patient is still conscious. The nurse's focus will be on ABCDE approach, like you've seen our assessments, because these stable SVTs can also happen during hospitalization. So when you have such a patient, you have to do a systematic ABCDE approach, and all vital signs are in this assessment. You have to do ECG and cardiac monitoring as your priorities, because this will help you identify life-threatening rhythms earlier or even prevent them from happening. Remember, these SVTs are peri-arrest arrhythmias. It means your patient can arrest at any time. So you have to make sure you have continuous monitoring. IV access is very important because it allows you time to administer emergency medications. Then the Valsalva maneuvers that Isaac talked about in the pre-hospital care. In case you have prescribed medications for a stable SVT, we administer adenosine. However, the nurse's effort will focus on warning the patient about the chest discomfort and the feelings of doom before administering adenosine. When we administer this drug, patients usually feel like they are going to die. It's a very, very bad feeling. That is why it's important for the nurse to reassure the patient that this is going to happen, but it is part of a process. Adenosine also has a tendency, adenosine also causes a slight pause, so it will give you a flat line before the heart restarts. So in this case, we don't call that an asystole. So it is not warranted for you to start chest compressions. That is part of the action of the adenosine. Then when we look at the unstable SVT, the unstable SVT is where your patient has signs of shock, like the patient that we have assessed in hospital. Our patient had cold extremities, a delayed capillary refill time. He had hypotension of 80/60, which automatically puts this patient as unstable. Other things that can be looked out for are signs of acute heart failure, chest pain, or what some people call angina pectoris. And this is usually indicative of myocardial ischemia. Another one is syncope or a history of fainting. So in your assessment, if you realize that your patient has a history of acute coronary syndrome or myocardial ischemia, and also a history of syncope, that patient qualifies to be unstable. And in this case, we move on directly to synchronized cardioversion. Now, there are some safety precautions that you have to take during synchronized cardioversion because this is a very painful procedure. Therefore, you need to seek consent from the patient. You need to sedate and give analgesia to prevent that muscular contraction that causes pain during the shocking. Then also, you need to ensure safety. Safety means you have to make sure nobody is touching the patient when you're going to deliver the shocks. But also, if you have open oxygen delivery systems like nasal prongs, face masks, you have to disconnect them because they can pose a risk for fires. Those are some of the safety precautions you must take when administering synchronized cardioversion. Then also, some people always wonder whether the rhythm comes back instantly. Now, with electricity, the rhythm has to come back instantly. That's why you have to continuously keep monitoring. It should work immediately. If it does not work, you have to deliver another shock. If it does not work, you have to deliver a third shock. And after the third shock, you now have to consider other medications, which we call chemical cardioversion, things like amiodarone, procainamide that can help you according to the setting where you are placed. Moving on to the nursing care plan. Now, the nursing process is very important in all these steps. These are things that we do on a daily basis, but sometimes we don't actually know that we are doing the nursing process. For example, if you look at how we did the systematic assessment of the ABCDE, that is part of assessment in the nursing process. Part of the subjective data that we had, our patient was feeling rapid palpitations, and these were self-reported. In the objective data, we had a heart rate of 220 beats per minute. We had an ECG showing us an SVT. We had signs of shock where we had cold extremities, a capillary refill time of over 4 seconds, and reduced blood pressure of 80/60 in your assessment. Now, what nursing diagnosis can you derive from this case? There are quite many because our respiratory rate was 24. You could say there is ineffective breathing pattern. But most importantly for this patient is the decreased cardiac output, which was related to the altered rhythm and evidenced by a delayed capillary refill. And this is evident of decreased perfusion. Our goal as nurses is to maintain the normal heart rate and make sure your patient gains a normal rhythm. You have to make sure that your patient remains hemodynamically stable, because if they go south, you might get into a cardiac arrest. In some of the interventions that we did, we had early IV access, oxygen administered, because remember we said our myocardial muscle is demanding oxygen, and then we placed the patient on continuous cardiac monitoring. We also took off samples for monitoring electrolytes. And we monitor electrolytes because imbalances in electrolytes can actually trigger arrhythmias. The second nursing diagnosis, which is anxiety that is related to the feeling of palpitation, And this is usually self-reported because the patient was restless in the beginning, very weak. So your goals of care should focus that the patient should verbalize, reduce anxiety, and demonstrate relaxation. In our intervention, we reassured the patient the environment was calm and made sure that the patient feels attended to. And we stayed with the patient during the whole set of intervention. So in your reassessment, you have to make sure your patient has a sinus rhythm, which we achieved, and a reduction in heart rate, which we also achieved. And the patient has to feel more relaxed and relieved of symptoms. Thank you very much for listening to me. God bless you.
Hey, thank you, Imelda, for that elaborate discussion on how to manage patients with supraventricular tachycardias. So we appreciate you, team online, for this long that you stayed with us, and we saw the feedback after the practical demonstration. A lot of you guys were appreciating how it was delivered, and we really take that feedback as a way of helping us to, as an encouragement to keep doing this. So the next thing that we're having on the agenda is going to be a presentation from Dr. Oriba Daniel Longoya. He's going to be discussing for us how to manage supraventricular tachycardia generally, or general patients with palpitations and tachyarrhythmias in the emergency department. I will take us through the investigations, management, and how we disposition these patients from the ED to the other units where they're receiving appropriate care. So, for the next couple of minutes, Dr. Oriba is going to do this. And at this point, I would like to welcome Dr. Oriba to take the mic and start your presentation. Right, over to you, Dr. Oriba.
Yeah, let me try to share again. I think let me get my presentation right. Okay. Am I really?
We can actually see your
Is it okay now?
Yeah, we can see your presentation.
Okay, fine. Thank you very much. Sorry for that delay. I'm just going to dive straight because the team has really done a great job on SVT. But I also wanted to point out that SVT is a general term which we are going to see, and it has so many arrhythmias, which again you also have to put a lot of emphasis on when you are looking at the ECG. So just diving straight, by the end of this, we think we should be able to define palpitations clinically, common and dangerous causes, and perform structured clinical evaluation for these patients. And we have to recognize the red flags that will help us to make appropriate investigations and referral for these patients, and also to apply diagnostic strategies which are very helpful in stabilization of our patient. And of course, document some of the important evidence-based management which are there for management of SVTs. So palpitation, basically, patients will tell it's an awareness of an abnormal heartbeat. So it's not a diagnosis, it's a symptom, and you need to find out what is causing it. Normally can be irregular forceful cardiac sensation, and so patients will give you several descriptions of it. Clinically, in the primary care, especially in emergency department and in the ICU, it's a common presentation. So we should be able to know, and also to have patients well triaged on what is causing their palpitation, cardiac versus non-cardiac causes. Of course, the second leading cause of cardiology referral, of course, most cases sometimes are benign, and then those, some of them are also life-threatening. In the emergency department, and especially in the ICU, you have to avoid treating the heart rate of a patient in sinus tachycardia, and if you feel you must treat the cause. This is an important quote, which I think we should have it, because sinus tachycardia, by the way, is a form of SVT, only that it doesn't have an accessory pathway, just like, supraventricular tachycardia, atrioventricular nodal, and then the nodal reentry tachycardia. So it's actually a form of SVT, but it's benign, and it doesn't cause a lot of problems. So avoid treating it. You must treat the cause of why the heart rate of the patient is high. When you dive into the pathophysiology and major etiologies of supraventricular tachycardia, you have to look at arrhythmias, other arrhythmias which are coming in. You have to look at, does this patient has structural heart disease? So under cardiac causes, you are likely to go into that. And then of course, some patients would develop supraventricular tachycardia when they have chest infection, especially in the elderly people, when they have a pneumonia or any other thing that, a COPD or lung infections or lung pathologies, they can present with supraventricular tachycardia. Types of supraventricular tachycardia that you should know is atrial fibrillation and atrial flutter is also regarded as a supraventricular tachycardia. And then SVT, which are part of ventricular arrhythmias. There are types of SVT. That is what we call the atrioventricular nodal reentry tachycardia and atrioventricular reentry tachycardia. So those are the SVTs, which we have seen in the videos and was responding very well to vago, to maneuvers, and also to synchronized DC cardioversion. Look for features of valvular heart disease in these patients, especially rheumatic heart disease and the rest. You need to make sure that you look for them. Non-cardiac causes. We underestimate anxiety, especially one of my colleagues was, Susan was telling me that please talk about anxiety. Patients can actually have stress disorders which can send them into palpitations. So we need to really know this. Hyperthyroidism, are they taking any drugs? Are they on caffeinated drinks? Anemia, fever, pregnancy, and then of course, anxiety and substance use. We need to make sure that we categorize these two very well so that we arrive at an appropriate diagnosis and at the same time help our patients receive the appropriate care. So in your assessment, you want to look at, in your history, the onset and duration. SVT is normally very abrupt and paroxysmal in terms of its onset. And then the triggers and the frequency. Is it really something that is constant, or, this is a new thing? Associated symptoms like, tremors, dizziness, and then you have to look at drugs and the cardiac history of this patient, and then the family history of sudden cardiac death, because we know that certain supraventricular arrhythmias can actually be related to sudden death in the family. So when you get that, it would be able to raise for you the flags. So the red flags that everyone should be very well versed with is syncope, chest pain, which could be due to myocardial ischemia, severe dizziness and dyspnea, and then of course easy fatigability. All these warrants urgent referral to a higher facility and specialized care, because you want your patient to be fine. Physical examination is very important. Like we have seen, you have to document the vital signs and then the pulse rhythm of these patients. Make sure that you palpate their pulse. In most cases, their pulse are rapid and weak, and normally it's very high. In SVT, normally you can document up to 150. Sinus tachycardia rarely goes above 150. So, certain things, if it is atrial fibrillation, you may document a pulse deficit whereby the heart rate is higher than the one you are palpating in terms of pulse rate. Thyroid, look at their neck. make sure that they are not having, any discharging T4s, which are so much in their circulation, and so they're in a hyperthyroidism state. Cardiac auscultation is important because from this, you are going to make sure that, is my heart dilated? Is there a regular rhythm? Is it irregular? Is there hypertrophy, especially if the precordium is behaving in a certain way? And are there murmurs? Can point to either rheumatic heart disease and so many other things. And then, of course, you grade your patients in terms of signs of heart failure, whereby you put them on a Framingham's criteria, major and minor, and you make appropriate diagnosis of what is causing the palpitation in this patient. And then, of course, the first diagnostic approach after doing all this, you need to request for a 12-lead ECG, which is gold standard in terms of capturing the rhythm abnormality in this patient, and then it is going to confirm for you what type of arrhythmias is there. So you will make a diagnosis of SVT, which is not enough. Then you have to go ahead. Is this SVT atrioventricular nodal reentry tachycardia, which you have seen on the video? Is this SVT part of atrial fibrillation? Is this SVT part of atrial tachycardia? Is this SVT atrial flutter? So all those things you need to make sure that you are you capture it very well. Going into investigations, we have seen ECG. Full blood count is going to help you a lot. Signs of infection, HB estimation in this patient. And then, of course, the thyroid function test, which will normally come later on. Make sure that you are up with your electrolytes and the glucose of this patient, random glucose, because there are certain electrolytes abnormalities, hyperkalemia and the rest can all send you into abnormal arrhythmias. Echocardiography, when indicated, you can do a point of care bedside echocardiography to look for any abnormalities of the heart. And then the most important thing we have seen, make sure that you treat the underlying condition causing the arrhythmias. Reassure the patient if it is a benign cause and control the arrhythmias. We know the control, one of the things that you have seen, you can control these arrhythmias with vagal maneuvers, you can control them with medication, and then you can go on to the last stage of, DC cardioversion. Acutely, which has already been emphasized, stabilize your patients using the APCs, and then of course go up to D and E. Continuous ECG monitoring and provide supplemental oxygenation if it is required. Urgent referral of those who are unstable is very paramount so that you find out the etiology of the arrhythmias. This diagram looks very crowded, but yes, it's very important for us to know, in the diagnosis of different supraventricular tachycardia, patients who come with palpitations in the emergency. As an emergency physician, as an emergency nurse, you are there. Make sure that after doing this ECG, you are able to, inform the doctor who is going to read this very well and make an appropriate diagnosis of either atrial fibrillation, atrial flutter, atrial tachycardia, or atrioventricular nodal reentry tachycardia, basing on what is being seen on the ECG. And we are going to see few examples of just passing over it to see how we can concretize our knowledge on it. This is the sinus tachycardia. It's actually, by the way, a very common rhythm. And if you can see from the arrow here, for sinus tachycardia, the rate is normally greater than 100, but rarely goes beyond 150, okay? So you find that there is a P wave, which is here, before every QRS complex, okay? So this is a P wave, this is a P wave, and then there is always a QRS complex, and it's a regular rhythm, okay? So from ARA to ARA, it's normally very regular. And then, P wave before every QRS complex, and that gives you a sinus tachycardia. Atrial fibrillation. For atrial fibrillations, normally the atrial rate is high, and that's why patients with atrial fibrillations are very unstable, because you find that the atria is beating at 350 to 650 beats per minute, but you can have a slow ventricular response or you can have a rapid ventricular response. In this case, you don't see any P wave here, okay? You can see there is no P wave and it is irregular. The ara to ara is not the same as this ara to ara, and is also not the same as this ara to ara. Once you see that the P waves are probably not seen, and then the ara to ara is irregular, you are probably dealing with atrial fibrillations. Sometimes this ventricular response becomes so much that you have what we call atrial fibrillations with a rapid ventricular response when the heart rate is also very high, and these patients are unstable. Sometimes you can see what we call fibrillatory fine or to cause wave. You see these are P waves which are very many. They are like waves on the ocean. They are very small, and it's an irregular wave. So this is atrial fibrillations. For atrial flutter, for those who have done woodwork in O level, the sawtooth pattern normally gives you a very perfect definition of atrial flutter. And you can have the one with a variable block. In this case, you can have 1 to 1, and then 1, 2, 3. You can see 3 to 1 QRS, 1, 2, 3, 3 to 1, 1, 2, 3, 3 to 1. You can have atrial flutter, whereby you have variable blocks, either a 2 to 1, whereby you have many QRS, many P waves to only one QRS complex, and then it's a sawtooth pattern. So that is also part of it, but management varies really, and we need to just know about it. So if you see this rhythm, better seen, of course, in the rhythm strip, which is lead number 2, then you should be able to make that diagnosis. Now, when we talk of supraventricular term, we say it's a generic term and means atrial fibrillation, flutter, paroxysmal, SVT. But of course, I extracted this presentation from what I gave to our master, our students here in Gulu University on supraventricular tachycardia. So most of the ones that you are going to see in the emergencies are mostly paroxysmal SVTs. And so you can easily, and paroxysmal SVTs are there. You can see AVNRT and AVRT and atrial tachycardias. And the symptoms may range profoundly from those who are stable or none at all to those who are really, really very unstable. So this is the algorithm for diagnosis. And so I'm not going to go over this, but it's very important that you will see this in the recorded videos, and it's important for us to know them, how you approach, narrow complex tachycardia like SVTs. Is it regular? If it is regular, then are the P waves visible? If the P waves are not visible, like in this patient, the P wave was not very visible, you see it is AVNRT. So you will do your vagal maneuver, and then you can give your adenosine, or you can also give DC cardioversion. If it is not regular, then you are dealing probably with atrial fibrillation, atrial tachycardia, flutter, or multifocal atrial tachycardia. Now, the types of SVT and physical findings. Normally, it's not very important, of course, to know all these things, but on physical examination, normally during a tachycardia, for AVNRT and for SVTs, the first heart sound is usually loud, okay? And you have waves. The heart, the neck of the patient is distended, and you can see visible pulsations, okay? Sometimes you can see multiple heart sounds. You can hear multiple heart sounds, the fourth heart sounds, which is normally associated with atrial tachycardia. So those are some of the things that you get in physical examination. The mechanisms, we are not going to go over it. I think it is just a narrow complex tachycardia, which is due to a re-entry circuit. You can see this. It keeps on re-entering, and then the tachycardia is matched because you're having circuits which are not blocked at the AV node. So the typical symptoms of this is basically palpitation. Patient will tell you, doctor, I have palpitations. My heart, I could feel my heartbeat and it's racing. Several symptoms, of course, are associated, like lightheadedness, chest discomfort, and easy sensation in the neck, and sometimes the urge to urinate. And of course, syncope is very uncommon. If it occurs, then it's a red flag, and normally it's already in patients with the probably coexisting cardiovascular disease. The palpitation of SVT are sudden onset, equally abrupt offset, and termination normally occurs after some times if it doesn't terminate by itself. What you have seen on the 12 on the defibrillator, the rhythm of the patient. What if you do a 12-lead ECG? You can see that, the P waves are really not absent, but they are just hidden. Let us look at rhythm strip number 2. I think you're following the arrow here. In rhythm strip number 2, you can see this W thing. This is a P wave. And so supraventricular tachycardia, which is atrioventricular nodal reentry tachycardia, is associated with this short RP. So from here, you have a R wave, and then the P is here. Normally, the P is supposed to be here, but this P is not there. So you have a long P, Q, but a short RP interval. And so this normally tells you that whatever arrhythmia you're dealing with here, this is atrioventricular nodal reentry tachycardia, which is an SVT. And so you can start the vagal maneuvers in this patient. You can start, if the patient is hemodynamically unstable, no contraindication to direct DC cardioversion, you can go ahead and do synchronized DC cardioversion. So it's important for us to know the patterns. The rhythm is that normally the heart rate is high, greater than 150, and the P wave normally is buried either within the T wave or occurs immediately after the QRS complex. And you can see all these are P waves. These are P waves, okay? Management depends on the underlying heart disease. Strategies is normally rest is required for this patient, especially for those with occasional AVRT. Encourage them to lie down, okay, in a cardiac position, and then do the maneuvers. They can be holding their breath. Vagal maneuvers, carotid massage, Valsalva, and gagging can help terminate this. If vagal maneuvers fail, like in this patient, IV adenosine, 6 to 12 milligrams, administered rapidly, is the initial drug of choice, and in most cases, terminates the AVNRT within 1 minute. Other therapies that are very important, of course, is non-dihydropyridines, calcium channel blockers like IV verapamil, beta blockers, and synchronized DC cardioversion. That was excellently demonstrated during our session. Atrial tachycardia. Don't get scared with these ECGs. I've labeled it here. When you see atrial tachycardia, normally they are narrow complex tachycardia, and P waves are negative. The P wave is supposed to be facing up like this. You are supposed to be facing. The P wave is like a U. It's U shape instead of having an N shape. Like upwards is N, but this time the two P waves are inverted. Once you see this kind of tachycardia with an inverted P wave, okay, and there is a long RP, this is atrial tachycardia. When you see a short RP tachycardia, that is supraventricular tachycardia, which is atrioventricular nodal reentry tachycardia. So those are the things that the doctor at the emergency and then us, we need to learn. And I will give you the links of where to get good information and study on your own to get information on ECGs. This is atrial tachycardia again, and you can see the P waves are really, really inverted, and you can see that. And there is a long RP interval. These are atrial tachycardias, and their management is different. This beautiful diagram tells you how you can acutely treat supraventricular tachycardias. SVT, are they hemodynamically unstable? Are they hemodynamically stable? So synchronized DC cardioversion and adenosine is indicated for those that, like this patient who came to us, hemodynamically unstable, the BP is low, rapid tachycardia. Okay, those with hemodynamic instability, hemodynamically stable patients, you can give them vagal maneuvers, which are the initial management. And of course, if it fails, you can go to DC cardioversion. Again, it will tell you all the various type of supraventricular tachycardia. What we have seen on video was AVNRT, one of the supraventricular tachycardia. And then there are several others that you need to really know, and then you know how to really terminate it very well. So I put some few slides, of course, on atrial fibrillation and flutters because they are very common in our settings. They are sustained arrhythmias. And by 2050 in Uganda, by 2050, it would be threefolds. And in our setting, it tends to occur in younger patients who have hypertension and those with rheumatic heart disease. We really need to make sure that we know about atrial fibrillation and flutter. Globally, atrial fibrillation is associated with cardiac disease, hypertension, congestive heart disease, coronary artery disease, myocardial infarction, and of course, valvular heart diseases. So without treatment, atrial fibrillation increases the risk of death in these patients, and we need to really know it. We need to really treat them and refer them to the cardiologist for further care. So this is the pathophysiology of atrial fibrillation, which we are not going to go through it. But of course, there are so many things which are there, which brings about atrial fibrillations. So recognition of the problem. The clinical presentation of a patient with atrial fibrillation, also in the emergency, is variable. Most common symptoms are palpitation, dyspnea, fatigue, and lightheadedness, probably due to reduced cardiac output in these patients. And so sometimes, the patient comes in heart failure, and what you find out, what has triggered their heart failure is actually an arrhythmia, which is atrial fibrillation. So syncope, without significant sinus node dysfunction, sometimes they get rare pre-excitations. And then, of course, you need to also find the intensities. On your examination, you need to look at the intensities of the first heart sound, of course, because it's going to tell you the heart rate. Is it regular or irregular, or are there pulse deficit in this patient, which will give you physical examination findings of atrial fibrillation. So this ECG that you see, normally it's a chaotic rhythm. We call it chaotic because you don't see any very good atrial activity. You look at these P waves, they are just beating just like that. It's an irregular rhythm, okay? Then no P waves. If they are there, then they are just what we call fibrillatory small waves. And then rapid ventricular rate. These patients are likely unstable and you need to make sure you help them. So this is a patient who came to emergency with palpitation. Glasgow Coma scale was 15 out of 15. And then, of course, the heart rate was 190. BP was 75 out of 50. You can see this patient, with the atrial fibrillation, rapid ventricular response. You can see irregular rhythm, no visible P wave, erratically, really thingy. And the patient is hemodynamically unstable. You can see this BP. You need to work on very fast. So irregular rhythm, broad complex tachycardia, and it's atrial fibrillation with a rapid, ventricular response. So this patient underwent also direct current cardiovascular, which brought back to sinus rhythm and resolution to hemodynamic stability. You can see this, how it has come back, just like it has been done on the other one, okay? So this is also an elderly male with type 2 diabetes and hypertension. You have to describe this ECG, okay? This patient came to the emergency generally unwell. That's why I'm saying that you need to really know what arrhythmias really come in this patient. Again, this is really very different. Type 2 DM, poorly controlled. This patient had very bad hyperkalemia. You can see the tall tented T waves here and is in a tachycardia, almost impending sinus, sinusoidal, waveforms. And this is the patient that will probably come to you in emergency, and you really need to take history because he's a diabetic patient and with chronic kidney disease having complication of hyperkalemia, which needs urgent management here. Now, if you want to teach yourself ECG, guys, it's very important that you have to invest time. You have to put some dedication because ECG, people fear it for nothing, but it's a very nice tool for us to learn because it's going to save life if you make accurate diagnosis. Please kindly visit Life in the Fast Lane and click on the link above to make sure that you can, go to and read all the various ECG. They start from basics and they can help you to really learn ECG, and it's free of charge. You just need to make sure that you learn one ECG at a time. Again, this is a very nice tool that is available online. When I was doing my residency, this is an AI tool for interpretation of ECGs. And I think I was recruited to be uploading ECGs onto it. And by the organization now, they have given me institutional access. So if you have an ECG that is very difficult, you can also just send it to me with a brief history. We'll come back with the diagnosis very fast. But get your own version of PM Cardio. They will be able to give you at least 5 ECGs per month, which is okay. So you make sure you prioritize for those patients that are very difficult for you to interpret. But if you have one which is very difficult, this is a very nice tool and it's FDA approved to be used. Thank you very much. I think our take-home message is palpitations are a common symptom, not a diagnosis. History plus ECGs are very important cornerstone in making sure that you arrive at the diagnosis and manage your patient. You have to recognize the red flags, which are important early enough, and then management is cause directed. Thank you very much.
All right. Thank you, Dr. Oriba Daniel, for that great presentation. You've just really done a great job discussing how to manage a patient with palpitations. And you've really labored to take us through how to systematically go on and look at the different tachyarrhythmias, which could be, what cause a patient to present with palpitations. So to the online team, I think if you're to recall from where this all started, that would be the case of palpitations. We narrowed it down to a case of supraventricular tachycardia. Then at the end, Dr. Oriba has just widened it for us to take us through all the different possible tachyarrhythmias which might make a patient present with palpitations. So at this point, I would like to ask to proceed to the next item that we're supposed to have on our agenda, which is to have a session of question and answers. So if you recall at the start of this talk, we encourage you to keep the questions coming through in the chat, to ask any questions as the discussions go on. So we do have Dr. Daniel Orenga, who has taken note of all the questions that you're asking. I'm sure he was responding to some of those in real time, but there could be those that he kind of picked out to be, very unique and could benefit the entire team. So I'm going to allow him a moment to come in and share those questions that he believes were important to, have everyone get to know about and give answers to. So Dr. Daniel, if you could unmute yourself and share with us those questions that you picked from the chat that you believe worth sharing with the entire team online. Over to you, Daniel. But as well, to those online, you can keep some questions coming through in the chat, or you can as well put up your hand and we'll select you to ask any questions that you have before we get to the end of this talk. Over to you, Daniel.
All right. Thank you very much for the kind presentation, and to all the experts over there for really demonstrating these cases accurately. On the chat, most people were really happy with the outcomes for the scenario, and the presentations well done elaborately, all the way from Imelda to Dr. Riba, which actually answered a couple of questions that were here. And some of the key highlights that we saw and encountered on the chat were that a couple of members were still grappling with the ABCDE approach. And we said for all patients who are presenting to the emergency department, the index approach is having a quick primary survey, going through your airway, breathing, circulation. Then the add-on that you needed to understand better is disability and exposure. And so for every system, you need to assess that system, identify the problem, manage that problem, and then monitor. This is done before moving on to the next system. And this was clearly expressed on Mr. Peter when we went through the primary survey, where we identified there was a challenge. We managed to intervene. And case in point, going on to the next question then was where Peter had features of poor circulation, that is on C, and the team demanded to give IV fluids. So the question in the chat here was then, what is the use of IV fluids in patients with shock, especially those who are having cardiogenic shock? And so the caveat here is one, use of fluids in shock, cardiogenic shock, could help us to actually diagnose that this is actually cardiogenic shock, because the problem is with the pump, which is the heart, in that the more you add fluids, it actually worsens the picture of the blood pressure. Going back to the people who understand physiology, if you overstretch a heart that is already failing, you actually fail to pump out more. So one, it could be diagnostic. So if you already know that it's cardiogenic shock, you ought to use your fluids judiciously. Some of these elements, for instance, the heart is getting tachycardic. It could be because of the low venous return, post-load venous return to the heart. And so it pumps faster, trying to beat the little blood out that is filling the chambers to other parts of the body. So fluid again comes in handy. But then, like we have said judiciously, so we want to replace this fluid gradually at 10 mils per kilogram of body weight as you reassess. And we are saying this body weight, you can guesstimate depending on where you are. You have seen these various people. You've seen a tall person who is heavy and is about 70 kilograms. But if you are in a good setup, and thanks to the Ministry of Health, now have beds with height, Sister Imelda can actually attest to this. You look at a stretch hour bed and it's showing you centimeters of height. So use that and relate it to the chart of ideal body weight. So that can actually tell you what this patient's ideal body weight could be depending on the height. Improvise also with a tape measure. It doesn't hurt for you to quickly do that as well. And this takes us then to another point, which is a little advanced for those who are advancing, that as you are replacing this fluid, it's important to bring in your bedside ultrasound scan. It helps you to assess the inferior venous cover and also the fluid overload that may result. So looking into the lungs for the B lines, but most importantly, for this patient who is having a fast beating heart, you touch or you shine your ultrasound, which is a cardiac focus, point of care ultrasound scan, onto the heart and see if there are any changes in its contractility or dilatations and so forth. These are all done quickly. It doesn't replace the cardiologist echo, not the echo session, but the ultrasound that is done in detail to measure the different chambers of the heart. Otherwise, elaborations were made for what supraventricular tachycardias are and its examples, and the classic SVT itself that we have been singing about today, narrow complex. Always remind you bedside, if you don't know the detail, always look out for, is there a P or no P? And the question that followed the supraventricular tachycardia was one that I don't encourage you to cram. People were asking for, what number do we use to say this is a supraventricular tachycardia? Like Dr. Riba elaborated, even sinus tachycardia, which is benign, can actually push up to those numbers. But averagely, for adults, it's a number that is 180 beats per minute and above. Look out for the P wave. Is it there or not there? Then for children, pediatrics, it can be 200 and above. So when you're in those ranges, it gives you the suspicion to actually do your ECG and get to the bottom line. And management was accurately done following the algorithm. Go stepwise as you anticipate. These algorithms that we have, we tend to call them guidelines, but they are not God lines. It means you can adapt them to your patient before you. So as you're adapting them, say, okay, I'm doing my vasovagal maneuvers and the neck is short and thick. Will I really be massaging the patient for comfort or doing the carotid massage? My next step should be A, B, C, D. Should I now plan and tell the team to prepare for adenosine? Should I now tell the team to prepare for calcium channel blockers and beta blockers? You have the ultimate plan to do that. Most importantly is referral. So you need to set up the ambulance crews, the paramedics, the pre-hospital team generally, and the hospital that you're referring to, especially if you're in lower settings. Because if this persists, you don't have a defibrillator and etc., you run a risk of actually getting a cardiac arrest. But while you have prepared already, while you're managing this patient, it is imperative that you're in touch with the cardiologists or the senior physicians on ground or in the referral center. Otherwise, thank you very much. That was what was really highlighted in the chat. One of the last ones here was people were asking about use of sedatives in the cardioversion. So yes, one, we look at the fact that the patient came in with a tachycardia, and we want to really look into the drugs that are going to allay anxiety, sedate the patient, and manage the pain, because this is a painful process, and the team selected that accordingly in using midazolam. Midazolam gives you the anxiolytic and the sedative features, but may not give you that pain management. So you can add another drug, maybe an opioid like fentanyl, short acting, or even morphine to manage that part of pain. Importantly for those is that you looked at the heart rate that is racing. Now there's a common drug everyone picks up in the emergency department, and ketamine. Now ketamine drives people off the roof. You already have 180. You might get a giraffic heart rate of 300. So we say keep that far from your hands and use these others that may not impact much on the heart rate, but rather would even help you in lowering that heart rate. Today's session was not for shocking, so shockable and unshockable rhythms. We shall get another session for that. Can adrenaline be used in cardiogenic shock? That might be a topic of discussion for another day as well. But yes, in resource limited settings, we can employ adrenaline in cardiogenic shock, following the protocols and knowing what is causing the shock. Dating back to what Dr. Dan Oriba said, that identify the cause and manage that cause. Thank you very much. Over to you, moderator.
Yeah, all right. Thank you, Dr. Olinga Daniel, for those words. So I believe that all those that had questions, they've been appropriately responded to. So as we come to the end of this session, would like to project a post-session set of questions that we want you guys to respond to sort of give us an understanding of how much your knowledge has been impacted in this session. So the questions are over there, and we'd like you to take a couple of moments to respond to them, and we'll use that as an assessment to know how much this session has been impactful. All right, so I'd like to really appreciate everyone. We've had at some point close to 600 of you online. And so it's been a whole 1 hour and 44 minutes right now. We appreciate your consistency. We appreciate you for always standing up for these sessions. And just as a brief reminder, it's always Seed Global Health in partnership with Ministry of Health that bring to us these sessions every other fortnight. as we conclude, I'm going to. So yeah, as we get to the very last bit of this presentation, I'd like to have the experts give us their takeaway home messages from their presentations that they've made to you. So they're going to take around, starting from the one that's sitting just closest to me, and they'll take like a minute to talk to you about what the takeaway home points should be from this segment. So Imelda, if you can go first.
Good afternoon once again. I'd like to take this opportunity to appreciate each and every one of you that has taken time to attend these sessions. It is very important that you have a keen interest in more knowledge, which is very good in a dynamic medical field. Things keep changing and we need to always keep up to date with new standards and guidelines that facilitate our practice. I would like to extend my gratitude to my hospital, Bombo Hospital, which is a very, very big hospital that's providing a large catchment area in the Luero district that has given me this opportunity to also come and join the EMS ECHO. I would also like to appreciate Association of Ambulance Professionals Uganda, where I train as an instructor for advanced life support, that has also enhanced the moving forward of these sessions. I would also like to extend my thanks to the Ministry of Health, EMS, and the SID Global Health for facilitating these ECHO sessions to make sure all health workers in Uganda achieve the best of medical practice and also create change in the environments where they practice. My take-home message today is I would like to encourage all nurses and midwives and all other health workers to always look up to such things and engage in them. Boost your knowledge, invest in yourself, find short courses that make you a better practitioner in your field as a nurse, and do not shy away because you're the most important people in the medical profession. Of course, working with our colleagues, which gives a synergistic effect in the kind of care that we produce. Thank you so much once again for being part of this session.
All right.
All right. Once again, I would like to appreciate each one of us, the different cadres, different organizations, the participants, and the audience which has been following us. A take home for me to go straight to the pre-hospital personnel, the EMTs, the paramedic, is that at least we can do something. Guys, we can do something before we reach the hospital, which can be beneficial, which is actually beneficial to our patients. Okay, the maneuvers we do, they save lives, so we shouldn't shy away from at least doing something. I know we're working from different organizations using different ambulances, which may not be as necessarily equipped as you would like them to be, but with the technical skills, you can at least do something. Therefore, another take home may be not to waste a lot of time with the patient. Do what you need to do and rush the patient to the hospital, a definitive health facility for further investigations and management. Thank you very much.
Thank you.
Greetings once again. Thank you so much for this opportunity to be part of our presentation this afternoon. Once again, I would love to extend my appreciation to the attendees online and in person, to the technical team, to SID Global Health and the Ministry of Health. My take-home point is that in the hospital setting, we work as a multidisciplinary team, from the EMTs, nursing care, to the physicians, the MOs. So we should see to it that we are able to gel together in order to bring out the best patient-centered care. And on top of that, we should also, as Imelda said earlier on, we should acquaint ourselves with proper patient care management, looking at ECGs, such that we are able to know what to do and when to do it. Thank you very much. Have a beautiful afternoon.
All right. Thank you, Moses. So we do have other two experts online, whom at this point I want to also invite in to give us the closing remarks. And we can start with you, Dr. Oriba. You seem to be ready.
Yeah, thank you very much, team, for this wonderful session. I think the demonstration was really, really excellent. And may God bless you all for the wonderful knowledge that you have given to everyone. I just want to say that let us have a broad, diagnosis in a patient with palpitation, consider cardiac and non-cardiac, and at the same time also psychological aspects in these patients. And also to all the listeners, I implore you to always look for information because these things are online. We just need to make sure that we are interested in learning and you find that you will understand and you will be able to manage your patients better. Otherwise, thank you very much and may God bless you all.
All right. Thank you, Dr. Dan, for those points. Finally, we would love Dr. Daniel to also give us his closing remarks.
All right. Thank you very much. Just to add my voice to the voice of the people who have spoken before me. Thank you, the online audience. You keep us going. You give us the energy whenever you turn up in such numbers. We also thank the Ministry of Health and Seed Global Health for giving us the opportunity to reach out to everyone in different parts of the country, and to my fellow experts for the preparations and sparing your time to have these lovely moments with everyone. It really means a lot to my humble heart. That is not tachycardic, but it's racing right now. And so my 5 take-home points for everyone today is remember to always assess the patient for signs of instability. Sometimes the tachycardia that you're seeing is because of the hypotension or the pain someone is going through or anxiety. So assess those and fix as necessary. 2, differentiate between a narrow complex and a wide complex tachycardia, which Dr. Oriba went through appropriately, because some drugs may not apply on the others because this might push the patient into heart failure. Then remember that you have to understand the rate and the rhythm. Understanding this will actually send you to the specific arm of care that you may need to take at that point, especially when it comes to deciding if you need to cardiovert or not this patient. Then you also need to have a good P drug list that you understand best how to use. Please do not use drugs that you're not comfortable with, and always consult the specialists in that arm. Lastly, treat the cause. Identify the trigger of the tachycardia and then manage it. It could be electrolyte imbalance, it could be hypoxia or toxins. With that, I believe most of you have learned what to use, and go save the world. Thank you very much.
Okay, thank you, Dr. Daniel, for those words. So, folks, we've reached the end of this particular session. As a norm, at the end of it all, we usually ask you to turn your cameras on so we can, just have a moment together, take a screenshot just to keep the moment live even in years to come. But I think before we do that, I've seen a couple of people asking for where the link to the CPD points and then to the session content. Okay, so those links are being shared actually. One link is to the YouTube channel where you can find these videos at any time. And then also the slides actually are shared there. Then for the CPD points, a link has also been shared, which you just tap on and it leads you to where you can apply for those CPD points. All right, so if you have the cameras on, I think we can have that moment that we always have at the end.
Yes, thank you so much for joining this month's second or first EMS Eco session, the 110th one. For those ones asking about the resources, we unfortunately do not share to your emails. We have a microsite called the Seed Trainings Hub that you can go and check out. That is where we post all our session material for all the previous sessions that we have, including this one. You can follow us on our X, and you can also get the recordings of this at our YouTube, that is Seed Global Trainings on YouTube for the videos for every session. Thank you so much for joining in. Until next time, we can turn on our videos.
All right, so we can turn the cameras on and we take the screenshot. And the next session will be in 2 weeks, right? Yeah, so yeah, as a custom, every fortnight we have these sessions. So next one will be 2 weeks from now.
Thank you so much, Danny.
You first it out, please.
Thank you so much for helping us with such questions. Like you can see, Lucani Samuel, we can see Victory Jones. Thank you so much for attending. Kunda Tracy, Chen Kenneth. Thank you all so much for attending this week's session. Nawira Sharon. We can also see Robert Ojambo. Thank you so much for attending. Hillary, we can also see you, Sharon, Lameka, Navisi, thank you so much for attending as well. And the rest of you. Until next time.